A 55-year-old man presented with dysphagia. I am showing you his chest radiograph. Describe the findings.
Let me just study this for a second. Right. The chest radiograph demonstrates a triangular opacity behind the left side of the heart that obscures the left hemidiaphragm silhouette, associated with depression of the left hilum. This represents left lower lobe collapse. In the right upper lobe, there are cavitating pulmonary nodules. Additionally, there is residual barium within the upper thoracic esophagus, terminating abruptly in the mid-mediastinum.
What is the most likely primary diagnosis and the mechanism for these findings?
The primary diagnosis is an obstructing esophageal carcinoma. The esophageal tumor is causing dysphagia and the barium cutoff. The left lower lobe collapse is secondary to direct bronchial compression by the esophageal mass. The cavitating right upper lobe lesions are hematogenous pulmonary metastases from the esophageal primary.
I am showing you another chest radiograph from a different patient. Describe the findings.
This chest radiograph demonstrates right upper lobe collapse. There is a triangular upper zone opacity, limited inferiorly by the horizontal fissure. The central mass produces a characteristic S-shaped configuration of the fissure, known as the S sign of Golden, which is highly suggestive of an underlying bronchogenic tumor.
Now look at these axial and coronal CT chest images of the same patient. Describe the findings.
The axial CT images confirm collapse of the right upper lobe, showing anterior and medial displacement. There is anterior movement of the horizontal and oblique fissures. The coronal CT reformatted image clearly demonstrates the medial displacement of the collapsed lobe with significant volume loss.
I am displaying AP and lateral chest radiographs of another patient. What does this demonstrate?
The AP radiograph shows a characteristic veiling opacity over the left lung without a discrete edge, representing left upper lobe collapse. The lateral radiograph confirms that the left upper lobe has collapsed anteriorly, visible as a band of opacity displaced anteriorly.
Finally, describe the findings on this chest radiograph.
This radiograph demonstrates total opacification of the left hemithorax with a mediastinal shift, indicating complete left lung collapse. There is also right upper lobe collapse. A malpositioned endotracheal tube is visible, having passed too far and selectively occluding the bronchus intermedius, causing these collapses.
What are the common primary tumors that produce cavitating lung metastases?
Primary tumors that classically produce cavitating metastases include squamous cell carcinomas of the lung or head and neck, colorectal adenocarcinoma, melanoma, osteosarcoma, and transitional cell or cervical carcinoma.
How would you manage this patient as a radiologist?
I would compare the chest radiograph with prior films to evaluate the left lower zone collapse and pulmonary nodules. I would communicate the findings of suspected esophageal cancer with metastases immediately to the referring clinician. I would recommend an urgent staging CT scan of the chest, abdomen, and pelvis, and an FDG PET-CT to evaluate for systemic metastases. I would recommend an upper gastrointestinal endoscopy with biopsy of the esophageal lesion for histological confirmation. Finally, I would refer the patient immediately to the upper gastrointestinal multidisciplinary team and oncology for systemic therapy and consider esophageal stenting if dysphagia is severe.